All right, let's dive into obstetric ultrasound. We're going to cut right through all the complexity and build a really clear conceptual framework that's going to serve you well, not just for your exams, but in your clinical practice too. Let's get started.
So, have you ever found yourself looking at terms like CRL, BPD, AC, and FL, and just feeling like you're drowning in an alphabet soup? You're memorizing these acronyms, but you don't really get what they mean or why they matter? Well, don't worry, you're definitely not alone. It's a super common feeling.
But today, our goal is to fix that. We're going to turn all that confusion into real, solid clarity. By the end of this session, you're going to have a structured understanding of how we use ultrasound throughout pregnancy and, more importantly, why we do it.
We're going to follow a really logical path, one that actually mirrors pregnancy itself. We'll kick things off in the first trimester, where it's all about dating the pregnancy and checking for viability. Then we'll move into that all-important mid-trimester for the detailed anomaly scan. We'll wrap up in the third trimester by looking at growth and the power of Doppler studies. And then we'll bring it all home with the key takeaways you absolutely need to know.
Okay, so let's start at the beginning, the first trimester scan. Now, at this very early stage, ultrasound has two main critical jobs. First, to confirm that we have a viable pregnancy that's actually inside the uterus, and second, to establish a really accurate gestational age. So the very first question we have to answer is this an intrauterine pregnancy? And we do that by looking for a true gestational sac. Notice its key features. It's located eccentrically, so a little off-center. And most importantly, it shows what we call the double decidual sign. This is the sign that confirms the pregnancy is safely embedded in the endometrium. Now, this is so important because it helps us rule out a dangerous ectopic pregnancy, where you might see a pseudosac. Think of it like an imposter that's usually central, irregular, and empty.
Once we've confirmed the pregnancy is in the right spot, we need to date it accurately. And the absolute gold standard for this in the first trimester is the crown rump length, or CRL. And just like the name says, it's a simple measurement of the embryo from the top of its head right down to its bottom.
And here's a point you absolutely need to highlight in your notes, because examiners love this. CRL is the single most accurate method we have for dating a pregnancy, with just a tiny margin of error. So why is this so important? Well, because getting this date right from the get-go is the foundation for every single growth assessment we do later on.
The first trimester scan also gives us our first chance to screen for potential problems. We do this by measuring the neutral translucency, or NT. This is that tiny fluid-filled space at the back of the baby's neck. A measurement over 3 millimeters is a pretty significant soft marker for chromosomal conditions like trisomy 21. Now, it's really important to understand this isn't a diagnosis. It's more like a flag that tells us, hey, maybe some more counseling or definitive testing is needed.
So, as we move out of the first trimester and into the second, our focus with the ultrasound shifts, and it shifts dramatically. We figured out the where and the when of the pregnancy. Now, it's time for the who, diving deep into the baby's anatomy with the big anomaly scan.
The timing for this scan is absolutely key. We do it between 18 and 22 weeks, and this window is just perfect. It's the sweet spot where the fetus is big enough for us to see all the organs clearly, but there's still enough amniotic fluid and space to get a really good look at everything from head to toe.
During this scan, we take a few key measurements. The first two have to do with the baby's head, the biparietal diameter, or BPD, which is basically the width of the head, and the head circumference, or HC. Together, these help us track whether the head is growing just as it should be for its age.
Now take a look at this image because it really shows you the kind of precision we're talking about. To get an accurate BPD and HC, we have to be in a very specific cross-section of the fetal head. You see those landmarks? There's the midline falx that splits the two hemispheres, and then you can see the cavum septum pellucidum and the thalamus. We have to see those. Once that view is perfect, the BPD is measured from the outer edge of the near skull bone to the inner edge of the far one.
All right, next up is the abdominal circumference, or AC. And here is another one of those absolutely crucial high-yield points. If CRL is king for dating the pregnancy, then the AC is king for assessing growth. In fact, it's the single most sensitive measurement we have for monitoring how well the baby is growing and for catching issues like fetal growth restriction early on.
And just like with the head, precision is everything here. The AC has to be measured in a very specific plane. We're looking for this nice circular cross-section of the abdomen where we can clearly see three key landmarks: the portal vein, the stomach bubble, and the spine. Seeing all three confirms we're at the right level, at the level of the liver, which gives us that accurate assessment of fetal size.
Sometimes you'll hear the anomaly scan called a genetic sonogram, and that's because we're also on the lookout for these subtle signs or soft markers that might hint at an increased risk of a chromosomal issue. This table here summarizes the key ones. For example, finding something like a choroid plexus cyst doesn't diagnose anything on its own, but it's a flag that tells us, hey, maybe we should think about a more detailed chromosomal analysis.
Okay, so now we're in the home stretch, the third trimester. At this stage, our focus shifts again. We've already set the dates, we've checked all the anatomy. Now the main job is to monitor fetal growth and, most importantly, to assess the baby's well-being, especially if it's a high-risk pregnancy.
And this is where Doppler ultrasound becomes such an incredible tool. It's actually not as complicated as it looks. At its core, Doppler just measures blood flow. The color coding is really simple. Just remember BART, blue away, red towards the probe. By looking at the blood flow patterns in vessels like the umbilical artery, we can get a great idea of how well the placenta is working and how well the baby is being oxygenated.
And this is why it's so powerful. See, if the placenta isn't working well, it creates high resistance to blood flow. On a Doppler scan, this shows up as reduced or even absent or reversed blood flow during diastole. Seeing that is a major red flag that the fetus might be in distress, and it helps us make really critical decisions about the best timing for delivery.
All right, let's take a moment and consolidate everything we've just covered. Think of this as your high-yield summary, perfect for that last-minute revision before an exam.
First, let's clear up a few spots where students often get tripped up. 1. For dating, CRL is king in the first trimester, no question. After that, we use a combination of all the measurements. 2. Remember the difference between growth and age. AC is our best tool for monitoring growth, not for setting the due date. And 3, always remember that soft markers are about risk, they are not a diagnosis.
Okay, and here are the absolute must-know facts for your exams. Ready? Let's run through them. 1. Most accurate dating, first trimester CRL. 2. Anomaly scan timing, 18 to 22 weeks. 3. Most sensitive for growth, abdominal circumference. 4. Key marker for aneuploidy, NT greater than 3 millimeters. And 5. What does Doppler assess? Placental resistance and fetal well-being. Got it? Good. So, if you need to boil it all down to one single, easy-to-remember sentence, here it is. The first trimester is for dating, the second is for anatomy, and the third is for growth and well-being. It's that logical progression through the whole pregnancy. You know, ultrasound gives us this truly incredible window into life before birth. So for us as future doctors, the real question becomes, how do we take this powerful tool, all these measurements and images, and use them with skill and with compassion to ensure the healthiest possible start for every single mother and every single baby?